Okay, well, hello everybody, and welcome to the Healthy Joints, Healthy Lifestyle Show. And we have a phenomenal guest. Her name is Dr. Carla Bauman, and she's an amazing dermatologist in the greater Seattle area. So for those who don't know me, my name is Dr. Arinola Dada. I'm a rheumatologist. I help people with autoimmune disease get their immune system back on track, and people with joint pain become pain-free. So I am so excited to have my dear friend, Carla Bauman. She's been practicing, I think, just as long as I have, 20 plus years. We will not date each other here. We will not do that. But what we will do is have Dr. Bauman introduce herself, talk about, what she loves about dermatology and just a few things just so you get to know her. And then we can do a deep dive into the world of dermatology.
Hi, Arnola. Thank you so much for having me, dear friend. I have been practicing dermatology for 27 years and that, but we're not going to count. I'd like to do it for at least 27 more. We'll see. I love many aspects of dermatology in that it covers what I would say would be primary care down to tertiary care and very complicated diseases as well. We'll see someone who's a newborn, and the next patient might be someone who's over 100 years old. So there's a variety of ages and disease types that we can treat. There's a surgical component and yes, a cosmetic component, but the connection between dermatology and internal medicine is one of my biggest loves. And that's why working with people like your amazing self, Arnola, is so much fun to collaborate with you and share patients and hopefully make improvements for people in their lives.
I mean, it's been great kind of working with you over the years. Not to ding on your dermatology colleagues, but there's so much aesthetic derm out there. But the wonderful thing about you is that you cover the whole spectrum. So whether it's the aesthetics, the medicine, Dr. Bauman, I do not know what this rash is. I need your help to find out what it is, and you're right on it. I love your office. Like, I send the patient and boom, it's handled, right? So thank you for your service to the community. So today we want to talk about psoriasis. Actually, this is the last day of August, and this is Psoriasis Awareness Month. And so I got you just in time.
Yes. So it's always Psoriasis Awareness Month in our life.
It's crazy, just the social stigma that comes with psoriasis, right? It's kind of what really made me, I had a patient come in and just kind of reiterated that social stigma. And that's what made me reach out to you and say, hey, you know what, let's do another one. Let's do one of this and talk about psoriasis. So I'm going to ask you the first question that he asked, right? Which is, can you tell me the difference between psoriasis and eczema?
Sure. And I can talk about it. I do have some pictures if you want to show them, but
you know what I'm going to do? Actually, we're going to add this to the show notes, and during this conversation, when it's being edited, we actually have the pictures pop up. So,
all right, great. So briefly, eczema is an allergic process primarily, and it's either the immune or allergenic cell in the skin that turns on its own, or there's an outside trigger that triggers a certain type of cascade with very specific chemicals that cause swelling and what we say edema of the epidermis. So the epidermis is maybe people would think of as juicy or wet. There is scale, but there's also some erosion and sort of a weepy texture to the eczematous plex, but it's fundamentally an allergic process. Some skin types are missing certain lipids in their skin or have less of certain types of lipids in their skin that protect them from these allergens. And so these skin types are more predisposed toward getting eczema. And so that's treating the eczema with proper skin care. Products that have ceramides, for example, over the counter can be very important in preventing skin barrier disruption that can trigger eczema. But it's fundamentally an allergic process.
Okay, let me interrupt just there, just for our audience. So you kind of talked about it being in the epidermis layer. So that's kind of the topmost layer. And the lipid is more like a fat that's kind of missing and makes people just more predisposed to this allergic reaction, which sounds like that's really what eczema is. It's more of an allergic reaction. And some quote unquote deficiencies in that lipid or fat is really what is predisposing them to that wet, weepy kind of reaction. And is there a site that's more common in?
Well, classically, I'll see eczema on the eyelids or on the inside of the elbows, at the back of the knees, what we call the flexural points, or the points that are folded. But classically, we'll also see it on the hands, in between the fingers. Hand eczema is really a common thing. It can really impact someone's life so that they cannot function or work. And we'll see eczema spread from these locations to just the general locations, and just a red, scaly, weepy rash. However, in skin of color, sometimes it can present as a darker plaque, or interestingly, a lighter plaque. So the classic presentation of a red plaque on light skin is not necessarily eczema in a large, so it can be a lighter plaque and darker skin, or it can be a deeper purpley sort of color texture, but it's classically on the joints and the flexures of the skin.
Okay, so it's on the inner aspects of the joint, and the color can pretty much vary, it sounds like. We can't just rely on red. It can be darker, it can be purplish. Okay.
Yeah. And so psoriasis, that's a nutshell. I mean, experts on eczema would say that's very cursory, and I have to acknowledge that, yes, that's true. But that, in a nutshell, that's what eczema is.
But that's I think that's what our patients want to know, right? And then, yeah, I think they don't know that they want a PhD on it, but I think that's actually very detailed enough that I think it helps them even identify, and even maybe be able to say, okay, you know, this is most likely eczema. You still need to see your doctor, but at least, you know.
Yeah. So psoriasis is a genetic component. Now, there's a genetic component to eczema too, but psoriasis is a different gene component. And did I lose you? Can you still hear me?
No, I can hear you perfectly. I'm listening with rapt attention. I got my pen.
Okay, so psoriasis, the immune cell in the skin can get turned on by many different cells, many different factors, and that releases the immune cell gets activated, and therefore communicates with other immune cells that cause the skin epidermis, the top layer of the skin, to get thicker and thicker and thicker. So it's this thickening of the skin, but not necessarily a deep wet fluid accumulating in the skin the way you think of with eczema, but it's a thickening of the skin that is characteristic of psoriasis. And psoriasis can also occur on joints, but typically, if eczema is on the inside of the elbow, classically psoriasis you might see on the outside, on the knees or the outside of the elbows. In areas of trauma, psoriasis is very common, what's called cavernous, but basically it will occur in areas of trauma. It can occur in the scalp. It can occur as a reaction pattern. A lot of times young people, after getting strep throat, can get what's called a guttate psoriasis flare, and that can be it can be also in the palms and soles, and it can be in the nails, which is really in your domain, because nail psoriasis is really psoriatic arthritis and within the joint space of the nail, but that can present with pitting or these yellow oil-like drops under the nails as well. Again, we have to pay attention to the color of the skin, because in skin of color, the presentation might be a little bit different than in non-skin of non-color. And we have to know that sometimes it could appear red, but sometimes it can appear purple or even white. And then there can be what's called inverse psoriasis, which breaks all the rules and will go in the folds of the skin, which it's not supposed to. So you'll see it under the breast or under the arm, what we call the axilla, and that can present in these ways. There are many genes that can trigger this. It's not quite an allergic, it's more of an intrinsic reaction within the skin.
Okay, that is so helpful. And just, you know, recapping a little bit is for our audiences, you know, so the epidermis, the most part of the skin, is a part that's involved in both. The allergic reaction, eczema, is more of the eczema, and when your skin is kind of getting thicker and thicker, that's more the psoriasis. Psoriasis is more psoriasis, and it may be associated with psoriatic arthritis in about half of the people. And if it starts affecting the nails, we're always thinking in my world, that is now becoming more of a psoriatic arthritis. But there's a genetic component, and your immune system is more triggered when we're thinking about psoriatic arthritis rather than, or psoriasis rather than if we're thinking about eczema, which is more allergic. And then I think the other thing that people want to know is none of this is contagious, right? Because
Absolutely.
yeah, the person with the hand with psoriasis and the person that wants to shake them with psoriasis, both of them are like, oh, he's going to think it's contagious, but it's not contagious, especially moms with kids. I can see them getting worried. Your child has strep throat, and the next thing it busts out in this rash, and that could be gutted psoriasis, and it's treatable.
It's true. You treat the symptoms and you treat the strep throat infection for sure. I think it's very important to know that these are not contagious, and we're just out of the COVID world and masks and etc. I think people feel this anxiety if there's any suggestion of any kind of disease anywhere. There's still this reaction, and it's hard for patients with both eczema and psoriasis, especially trying to function. And the thing I should mention about both of these is that they itch a lot, and it can affect sleep, and it can affect school performance, it can affect school focus or work focus. So the itch component is really something that we have to address, but they're not contagious. They're not contagious.
Yeah, I had a patient that came in and she was like, she has not worn shorts or short sleeves since she was 20. And she's middle-aged now because of psoriasis. She's like, I don't wear them. I wear long sleeves. She teaches. And you know how kids are. They're going to point out the obvious. They're going to be like, excuse me, ma'am, what's that on your elbow? It's like, ew. So yeah, so she was so, I think if I remember correctly, she was somebody that you had taken care of and she was so grateful. But I think she then developed arthritis, which is, I think, how she ended up coming to me. But yeah, she said that, before you had seen her, she wouldn't go out without long sleeves and long pants, just because it was just so embarrassing for her and just really became more of a stigma, right? So that's something that I think both psoriasis and eczema patients suffering from that are dealing with.
People should know that more tools now to treat both these diseases than we ever had before. So there's really, in the past, there were these tar shampoos, these whole body ointment treatments that worked a little bit, but not very well. Now we have so many new sophisticated medications that we can help make people functional and feel very comfortable in their skin. There's definitely things we can do for you now.
Yeah, thank heavens for that. It's part of why I did rheumatology. It's like if they didn't have those medications to help people, I'm like, yeah, I'm gonna keep it moving here. You guys can't help anybody. I'm not in the hand-holding business. And so I think that has really changed kind of how we both treat patients, just the benefits of technology in medicine.
Yes.
People ask about the sun all the time. What's your thought on that? I always wonder if it's a double-edged sword. What dermatologists really feel about just go and sunbath and get rid of your psoriasis that way?
Well, of course, many dermatologists have what are called light booths, which seems like heretical for a dermatologist to have a ultraviolet light booth when we're spending all our time teaching about sun protection. I do not recommend sun exposure as a main treatment, even though that it has been done. The sun does quiet down inflammatory mediators. It does decrease inflammation, so I can understand why it's being used. But the thing I'd probably want patients to know with psoriasis and eczema, but particularly with psoriasis, is that there is an increased risk of skin cancers in patients with psoriasis. So going out there and getting a lot of UV light in especially type 1 to 3 skin, but not only, but especially in that type, I probably would not recommend going out there as sun as a primary treatment. That being said, many derms still use their light boxes. I do not.
Okay. So do you still have the risk, and excuse my ignorance, do you still have the same risk? I kind of assume that you guys must have filtered out the bad UV lights before you start putting patients on that.
Well, there's a narrow
It's
band
still
UV.
the same as, is it the
Well,
same risks as just out there in the sun all day?
I'm not sure I'm understanding your question. The light that
Okay.
the narrow band UVB, so it's a very narrow band that's considered safer. Nonetheless, I have seen skin cancers look just like a psoriatic plaque in a patient with psoriasis that just isn't really responding to treatment, and you do a biopsy and it turns out to be a squamous cell. So I personally, my view is let's not tempt fate and make it more complicated. That being said, many derms still use their light boxes, and
Okay.
but I choose not to.
Okay. So it sounds like it's safer. The limited band is safer than just sitting in the sun all day, but it's not perfect because there already is this additional risk of malignancies, of skin cancers if you have psoriasis, period. And you can just keep treating the same thing, not realizing that, hey, this is actually a squamous cell cancer or some other cancer. It
It's
sounds like.
that's exactly how I feel. But
Okay.
others, that's how I feel. Yeah.
Well, we're asking for your opinion. When we want their opinion, we're gonna ask them.
Fair.
Okay. So what next if so a lot of people have tried topicals, they have a closet full of different topicals. What's your thoughts on how do you approach treating people with psoriasis?
I think the number one question is how much does it impair their functioning? And for example, I had a patient who just had one plaque of psoriatic pustular psoriasis on the palm of on the sole of one foot that was only 1/3 of her foot. And this, you would think just using a little topical in such a small area would be reasonable. And this plaque just affected her functioning to a large degree. She couldn't walk, she couldn't exercise, she was scratching all night, she was miserable. And then I have patients
Mhm.
who have
Oh, I lost you there. We'll have to edit out this part. Let's see. Oh, I lost you there for a little bit, but I
oh,
think you're back. Okay.
okay. I have patients who have wider spread disease who don't feel as impaired. I move fairly quickly to the biologics. They're so effective and I feel that they're safe. In terms of if the topicals really aren't working, if we've used a really strong steroid for a few weeks, we've used non-steroidal topical ointments, and we're really not getting impact on the quality of life, or more importantly, the itch, I am going to move to a systemic fairly quickly. These molecules just work and provide so much relief to patients. I'm probably going to go there fairly quickly.
Tell me what a biologic is for our audience.
So a biologic is, you probably have seen the advertisements on TV and during Super Bowls and other times that these are molecules, medicines that some of them are actually an injection, similar to like an EpiPen type injection, and some of them are oral tablets, and then some of them are probably infusions that you provide in your infusion center. But they work on the specific mediators, the chemicals that communicate cell to cell that turn on these inflammatory processes. These molecules work to inhibit this communication and quiet down inflammation. So they might work in between cells and they might work within the cell, but they work as an antibody to a key part of the inflammatory pattern that quiets down and shuts down the process.
Yeah, I think that that's kind of brilliantly explained. In addition, when I think about biologics too, I like to explain to patients that it's kind of it's a technological advancement that we've had, and it really is able to go in there and target the problem rather than I think it's a more rather than just there's a room burning in the house and you stand outside and you just kind of try to put out the fire. Now you can walk to the room, close there, put out the fire, target it, walk out without causing a lot of collateral damage, right? I think that it helps because otherwise it's kind of scary, I think, for people. Biologic, I don't want any of that, but you really do actually want something that targets that molecule and really minimizes the risks of side effects elsewhere. But yeah,
Sure,
I think
absolutely.
yeah.
So when you have steroids, and I think a lot of people have had or know of heard of steroids, I kind of describe that as a sledgehammer that's hitting everything all at once. And as a result, there are lots of side effects because it's hitting a lot of pathways we don't want to hit. Whereas the
Yeah.
biologics are custom made for just one little enzyme, one little communicator between the cells, and it's hitting only that and nothing else. I think
Yeah.
that reason they're quite a bit safer.
Yeah, yeah, I like that. I'm going to take that. I like the sledgehammer. I'm going to compare it to like Thor's hammer. You're trying to kill a little cockroach and use Thor's hammer, and now you have a hole in the earth. Okay, good. So you know what? Tell us a story. Would you mind sharing a story about a patient who's had an amazing outcome after being under your care?
Well, gosh, I blush, but had some, I'm thinking of two patients. One is the one I've mentioned with it's just this one patch under her foot that was driving her crazy, but we were able to use a new biologic topical molecule that's new, that's a brand spanking new, that is a biologic just applied topically, given that it was such a small area. And she came in tears because it was the first time in years she was actually comfortable. It just really speaks to even a small area can impact a person in such a
Yeah,
large and profound way. Then
yeah,
I'm thinking of a gentleman who's a truck driver who's out there on the road and lives a very physical kind of life out there on the road and had close to 70 to 75% of his body skin surface area being one large inflamed plaque.
wow,
And we were able to turn that and improve it so that with these shots once every 2 to 3 months, he was able to function normally. The
wow,
thing about something like that is profound because when there's that much burden on the skin, there's a lot of protein loss, and associated with psoriasis is a strong predisposition toward heart problems as
yeah,
well as diabetes. So
yeah,
being able to treat the psoriasis, we're also helping to treat these other conditions where someone in this kind of lifestyle,
yeah,
active but for many hours awake but not necessarily moving, it's at risk for other comorbidities that we were able to
yeah.
treat psoriasis and help treat these other
Yeah.
entities. Is That's very satisfying.
Yeah, that's amazing. I love that story. But it's so true, right? That it's not just one entity. So you can say, oh, I can just live with the skin. Well, it's not necessarily so, right? Because that inflammation is more in the whole system. So we call it systemic, and it may be associated with heart disease, right?
Mhm.
Because there's inflammation everywhere, including the blood vessels to the heart, may be associated with diabetes. So there are lots of other conditions that are associated with it. And of course, it's associated with arthritis. And the thing about psoriatic arthritis, though, is not very forgiving. It's like, I call it a bully. It goes after one joint at a time. It goes after one joint, it damages the joint, goes to the next, damages it, it just keeps going. Right? Rheumatoid arthritis will kind of sit around a bit and, chill. It doesn't necessarily go like aggressive, I'm damaging this joint immediately. Right? It's just psoriatic arthritis. So that's another thing is that, people who have psoriasis, about a third of them will get the psoriatic arthritis. And so probably important, I would say, if you have psoriasis, you should probably see a dermatologist. And if your dermatologist is concerned about arthritis, you probably should see a rheumatologist. And I would say this is one of those ones that you don't want to sit on it, just because the damage can be irreversible. I hate it when I say, well, this wrist doesn't move anymore, but we've got the other wrist to protect, right? We only got two wrists. So we, and so that's the benefits of the biologics that Dr. Bauman was talking about. And so thank you so much for just kind of reiterating just how, how much of the system is involved, and it's not just skin alone.
I,
Okay.
I agree with you, and I would actually reiterate how important it is when you even begin to have joint issues to get treatment for those joint issues with a rheumatologist such as yourself, because you're absolutely right. The skin we can reverse and make normal again, but the joints we can treat it, but I don't think you can reverse it.
We
So
can't reverse it. Yeah.
the sooner it's treated, the better.
Yeah.
Yeah.
Yeah. So on the Healthy Life, Healthy Joints show, we like to give our viewers some wins. So can you give me and our viewers 3 tips that we can implement. And it doesn't have to be just psoriasis. It could be anything that you think will really help us with our skin so it looks nice and glowing like yours.
Well, yours looks beautiful too. Well, in general, of course, I'm going to always recommend sunscreen. What kind of dermatologist would I be if I didn't do that? I like sunscreens that are at least 15% zinc. They have some new ones that blend into the skin nicely, and they're tinted. And I really like the tinted mineral sunscreens for number one, in skin of color. You don't look like you've got this white stuff all over your face. And number two, the iron oxide, that is the iron oxide that is the tint, that is the iron oxide, will protect against visible light. So the zinc will protect UV light, skin damage, skin cancers. The visible light spectrum, if we can block that, will help prevent against things like melasma, or sometimes people get this mask with birth control pills or with pregnancy, or these darker spots that come out just from visible light. So I like the tinted mineral sunscreens. And there's a whole bunch of them out there in the market. I'm not really wedded to a brand. There's just a whole bunch. In terms of moisturizers, I like moisturizers in general that have something in it called ceramides. Ceramides is sort of a fancy term for a triglyceride, and I think they're called ceramides. My personal thought, and perhaps I'll be corrected, but my thought is that the marketers didn't want to call them triglycerides because we're all trying to lower our triglycerides and not smearing on the skin. No one would buy them. But in fact, that is the lipid that is frequently missing, especially in certain populations that are predisposed toward eczema. So there are some moisturizers over the counter that have these ceramides in it. There's a brand we've all seen probably called CeraVe,
Yeah.
Eucerin with a red top,
Yeah.
the ceramide. There are probably others, but
Yeah.
A fragrance-free moisturizer with ceramides is for daily care, something I'd recommend. One little quick tip is that something that is unscented is not fragrance-free. An unscented product has a masking fragrance in it that masks all the other fragrances. So for people whose skin is sensitive, you really want a fragrance-free, not an unscented product. Just a little tidbit. You asked for three.
I asked for, yeah.
Okay,
I'm taking notes.
I would say with regard, well, for all diseases, but specifically psoriasis, associated with that is, as we mentioned, this metabolic syndrome or predisposition toward diabetes. So really trying to eat healthfully and get regular skin checks, looking for skin cancers, the whole picture. It's not just of the skin. And it's sort of this circle, because if patient also has arthritis, it's hard for them to move and exercise, and that leads to a more sedentary life, which makes it more likely to develop into this metabolic syndrome. But anything that we can do to have a healthy diet, what we call a low glycemic diet. People ask me, should I avoid wheat? Should I avoid this? And I really don't have a specific, like, it's not like carrots are good and cucumbers are bad or something like this, but it's just a diet that is generally what we call lower glycemic. So not a lot of refined sugars. That type of diet would be helpful in controlling some of these inflammatory conditions in the skin.
Okay, so I'm going to recap here because this was too juicy. These are like 3 different consultations in one. So first of all, we're going to use protect the sun with SPF, right? 15% zinc. We want the tinted one because iron oxide will protect us against the visible light, and that's what caused that bad melasma that I used to have when I was when I was younger and on that pill. Okay, and the second thing is to moisturize plenty, and examples like Eucerin and CeraVe, and it has the lipids that some people that have eczema may be missing. And you want to use a good thing that fragrance-free is not unscented, okay? Unscented is still a scent in there. So you want fragrance-free. That was helpful. I made a note. And then, the metabolic syndrome, people with psoriasis are predisposed to metabolic syndrome. You want to eat right. I think we all know, when you're eating something, it's not good. Okay, donuts are not good, So you want to eat the things that have low glycemic index, right? And
heaven knows I'm still struggling with it, but it does help. It can help. Yeah.
Yeah. Well, This is amazing. So I have one last fun question for you, and then you have to tell us how to find you, because I'm sure people are like, clamoring for more. So fun question. What superpower do you wish you had, and why?
Well, I kind of wish I were like Elastigirl in The Incredibles, or that's just the person that I respond to. The idea that she can do so many things and still be a kick-ass mom and kick-ass with the family, but can also do martial arts and get spread out in 10 different directions. I think Elastigirl's my hero. So that I'm going to hold her up as my example of.
Well, I can see that in you already. You already do most of that thing. So I think you already you just want to do more of what you do already. Yes. Wow, this was amazing, Dr. Carla Bauman. So can you tell our guests, how they can find you? Because I'm sure they're just chomping at the bit to kind of say, hey, you need to help me fix the skin condition, whether it's psoriasis, eczema, and the whole slew of things that your office provides. And you have an amazing team, because we've worked with them in the past.
Thank you. You're so kind. Thank you. I'm in Bellevue. My address is 626 120th Avenue in Bellevue. It's Suite B as in boy, or Bauman 104. If people are familiar with Bellevue and they know where Uwajimaya is, or Total Wine, if you go across the parking lot and get your latte at that Starbucks and go straight out the other door, we're across the street. So that's where you can find us. And we are accepting new patients, and we
Perfect.
love to help you out if we possibly can. We'd be honored to.
Website?
Website, Carla Bauman Dermatology.
Okay. Perfect. So Dr. Bauman is in the greater Seattle area. If you're in the greater Seattle area, please look her up. As you're aware, my name is Dr. Arinola Dada. If you were in the greater Seattle area and you need to see a rheumatologist, look us up at overlakearthritis.com, and we will be happy to help you on your journey to a healthier version of yourself. Thank you, everybody.
Thank you. Thank you, Arnola.
Bye. Bye.